Good morning, everybody. I'm going to welcome Dr. Robert Sapien to Phoenix Children's Hospital. I'm really excited to have him here today from University of New Mexico in Albuquerque, where he's the Chief of Pediatric Emergency Medicine. He also serves as Associate Dean for Admissions and Director of the combined BA/MD program. After attending college and medical school at the University of New Mexico, he completed a pediatrics residency and a pediatric emergency medicine fellowship in Los Angeles, California. He has a track record of successful HRSA EMS for children projects, including school nurse training, EMS interactive learning, online learning, and regionalization of pediatric emergency medicine services. Today, he will tell us about the confluence of some of these projects, the use of telehealth, and the creation of a virtual pediatric emergency department as a model for regionalization of pediatric emergency care. It's my pleasure to welcome Dr. Sapien.
All right, well, thank you very much. I tend to walk. I'm going to have to glue my shoes to the floor. It's okay. So this is intended to be very informal. We're going to talk a little bit about regionalization, and then we'll talk about some of the things that came out of our regionalization project and where we're headed now and in the future. I don't have any financial disclosures that are relevant. Wish I did. That would mean I had money. I don't. So we're going to talk about models of regionalization as well as what a virtual pediatric emergency department is. Recognition of our grant funders. So we have 3 grants that support this work, all of them from HRSA, different agencies in HRSA. We have the State Partnership Regionalization of Pediatric Emergency Care Grant, which we're in ending year 1 of 4-year funding for that. The EMS for Children State Partnership Grant, which is also HRSA funded. We've been fortunate to have continuous funding from that program for the last 27 years. And then we're in year 2 of 3 of a Rural Child Health Poverty Telehealth Network grant. That's from the Office of Rural Health Policy through HRSA as well. These are our local partners. So our program is called Child Ready. We'll talk about that. We do partner with EMS for Children. I happen to run both programs, so it's a nice partnership. It's an easy negotiation. And then we partner with the Center for Native American Health at the university and the Office of Center for Telehealth as well as the University of New Mexico. This is our team, and just through the talk, just a disclaimer, if I ever say I really mean we, and if I ever say we, I really mean they, because they're the ones that do the work. From your left is Matt Lepsick. He works for the Center for Telehealth. He's our technical advisor. Then Chuck, who does all our contracting and billing for telehealth. Then there's Norman, who is former governor of the Zuni Pueblo, and he's our cultural liaison for the program. Dr. Bullard Barrett in the middle is our medical director for our virtual pediatric ER. Then there's Christy McCauley, who is our telehealth coordinator. Sarah Dakin, our nurse educator from the pediatric emergency department. And then on the far right is Catherine Schaefer, who's the boss of all of us. She's the program manager for all of our projects. So as we started this work, I started to hear more and more, especially from our native friends, that especially around borders, and this was one quote that came up. Actually, it came up at an admissions meeting. We had Dr. Dan St. Arnold was one of the members of our admissions committee, and we were just talking in general about how we consider applicants for the medical school, and he reminded me that we're the ones that drew the state lines and county and country borders that divide. And he's from the Ojibwe tribe, which those people are up north by the Canadian border. And I thought this was really salient as we talk about borders, talk about regionalization, and talk about getting care to kids wherever they are. So just a little bit about comparing the two of us. So we're a little bit older than you. We're a month older, so we're not quite twins, but we were Siamese at one point. Both of our flags are based on the colors of the flag of Spain. Ours has a Zia tribe, which is one of the Pueblos symbol. Yours, of course, are the Colorado River, the blue at the bottom, and the copper mining star. You have 3 times the population of us, but we have more land mass than you do, so we're much sparser in population. And so there are several other differences. including financial differences and economic differences. And as a state, you all have progressed much more rapidly. Actually, the four corner states, you and Colorado have outperformed the others, followed by Utah. We've lagged way behind in the financial, and many times, well, most years, we're ranked 49th or 50th in the country in poverty. So when we do this regionalization work and telehealth work, especially getting care to the kids in those rural areas where they're so poverty-stricken, it's really, really important. We originally were all one. We were the New Mexico Territory, and then that split apart as we became states. Originally, the Gadsden Purchase is I had to review all this because I didn't remember it from history, but the Gadsden Purchase is what completed both the parts of New Mexico and Tucson, and that was purchased for the ease of putting the railroad through. In 1906, though, we were kind of had a different layout, where we were the northern part and you were the southern part. But now we're completely separate states. We do have similar amounts of Native American people. So we have, I think, 21 tribes, and you have 22 tribes in Arizona. We are much more, because of the poverty, et cetera, much more medically underserved. The green are underserved areas determined by the federal government. Blue, those determined by the governor. And then yellow is where there's a specific population that's medically underserved. White is where there's no data available. But you can see that most of our state, except for two counties, Los Alamos County and Bernalillo County, where Albuquerque sits, most of our state is medically underserved. Again, another reason to really push for regionalization and telehealth as we go through. Our demographics are quite a bit different. Arizona on the left, New Mexico on the right. We are one of only 4 minority-majority states in the country. Native American, red, Hispanic, blue, so we're about 53% or so minority, and you all are still the majority state. If you look at percentage of tribes, number of tribes, though, we have very similar in that. Counties that are medically underserved, 100% of yours reportedly are underserved. 97% of ours are. 30% of your population is Hispanic, 46 for New Mexico. And Native Americans constitute about almost 11% in New Mexico and about 4 to 5% in Arizona. So when we talk about regionalization, there's a lot of terms that kind of get thrown around and a lot of terms that kind of get mixed up. And so we're going to talk a little bit about some of those. So categorization, designation, accreditation, verification, licensure, catchment, and then ultimately regionalization and what that means. So categorization is where there's an inventory that occurs. There's an assessment and cataloging of capabilities, such as parts of the trauma center system may be, you may have a categorized facility, okay? Designation, also very familiar to trauma designation. That's where you're granted a charter by capability. And so designation is followed by a verification. So a verification is where an outside entity comes in, reviews and assesses your facility, verifies that you have those, and then you end up getting designated. So that's a stepwise process. Accreditation, that's attestation by an outside agency. That's the old dreaded JCO is one type of accreditation that occurs. Licensure, usually from a governmental agency or a governmental body, such as your Department of Health licenses your hospital to care for patients and see patients. And then catchment, and here in the West, our catchment areas are very, very broad and very large. They're mostly historical, negotiated, and informal many times. We've always transferred to Phoenix Children's, or we've always transferred to Albuquerque. So those may be just historical, and sometimes they don't necessarily even make sense, okay? For example, the Navajo Nation, which crosses both of our states, 2/3 are in Arizona and 1/3 are in New Mexico. That we refer to them as Big and Little Navajo, and so Little Navajo refers to Albuquerque. Some of Big Navajo also refers to Albuquerque, and then the far western part, of course, sends to you all. For EMS, though, all of Navajo Nation, including the 2/3 that are in Arizona, follow New Mexico EMS policies. Okay, so just really kind of depends on historical and negotiated and those informal things that occur. And then there's regionalization, okay, and regionalization is what we'll spend more time on. Some examples of all of that. So the NICU category is a categorization, an accreditation, and is a designation, okay? They're levels 1 through 3D, where 3D is the highest level. Trauma centers and trauma systems are a categorization and a designation and accreditation. There's also verification in those as well. And just because things can't be any more clear, 1 is the highest level for a trauma center in levels 1 through 4. STEMI, those are categorization and designation, and strokes are also categorization and designation. There are some efforts nationally to regionalize and categorize and designate pediatric emergency care. The first ones to come on board were Los Angeles County, where they did an EDAP system in the county and then spread that statewide. Illinois is also a leader, and Tennessee are also leaders in the country as far as designating a pediatric capable hospital. Arizona with Tommy St. Mars at the Department of Health has done a lot of work on this as well, which I'm sure you're aware of. So when we look at NICU categorization, designation, et cetera, it's really serving a specific population, and not to offend any neonatologists in the group, but arguably specific diseases as well, right? There's a limited number of diseases that occur in the newborn period. Trauma, it's a specific disease that it all revolves around. STEMIs, again, a specific disease, and stroke are a specific disease. Okay, when you're talking about pediatric emergency care, though, it's really trying to address a whole population across a large span of ages that can change dramatically because of development, of course, as well as a number of diseases and processes that occur. And so it's a specific population, but it's a broad and general population. If we go one step further, though, so of all of those, pediatric emergency care categorization is the only one that's specifically for outpatients. Trauma is inpatient predominantly with the trauma systems, and centers are really designated and accredited around care of the most severely traumatized individual, and so usually those are the ones that are admitted to the hospital, and those are the ones that are reported to the trauma registry of those more severely traumatized ones. NICU, of course, is 100% inpatient. STEMIs and stroke also are inpatient. So emergency care is the only outpatient. So now we're talking about a specific population that is outpatient, and that can present a lot of problems when you're trying to regionalize care. So regionalization is really getting the person right care, right time, right place. And for kids, all of us in this room who are interested in children, of course, it's particularly important. You know, the whole saying of kids aren't just big adults is absolutely true in all settings, all right? So it's a process of organizing resources within a geographic area to ensure access to medical care of an appropriate level to the patient's needs while maintaining efficient use of available resources. Now, regionalization has been determined to really improve care. So high acuity patients get care at facilities with resources, okay? There's improvement in the systems of care, and then off-site consultation in the management of patients can also be beneficial once you've regionalized, because once you regionalize, you have those relationships formalized. Those relationships already exist. I'm sure you get phone calls all the time from outlying facilities asking questions for consultation. So they de facto exist, especially in areas where you're the only show in town. You guys are the only show, we're the only show in Albuquerque. And so we do tend to get those kinds of consultations, but this formalizes that process. Okay? But there's positives and negatives to all of those. You're looking at high acuity patients. Certainly there's resources at the facilities that match the needs of the patient. So the sicker the patient, the STEMI, the stroke, the child, et cetera, the resources really match that. The negative, though, is that you can really increase costs quite a bit trying to develop the capability if you're not already known for that. So Phoenix Children's, you all are known for that, and so that's a little bit easier for you to add on those services as opposed to, say, another community hospital would try to beef that up and be able to take care of high care, acuity children with the same capabilities, okay? Longer travel time, of course, can cost the family. And especially in New Mexico, where, you know, we sit at the bottom of the country in poverty, especially with our native children, you know, waiting for the dad to get off work because they only have one vehicle, or waiting to borrow a dependable vehicle to drive the 200 miles to Albuquerque. Missing work, which does not usually come with sick leave for many of these parents, and so when they miss work, they don't get paid. So all of those are certainly increased cost to the family. And then it's really an inefficient if the supply exceeds the demand. So if you have a lot of centers that are all of a sudden advertising that they're stroke centers, then it really becomes very inefficient. Now you have a lot of centers that have developed their stroke programs, but that's not the need for that. As far as improving systems of care, you do have better coordination of care in the acute phase, and standardization of care definitely occurs across the system once you regionalize, once you designate facilities, et cetera, okay? The negative part is that it can require a lot of coordination between multiple centers. When I said Albuquerque, we're the only show in town, we're actually not. There's another pediatric intensive care unit that is, they don't have a pediatric ER, but they have a pediatric intensive care center. It's at a private hospital, and it's about 2 miles away. They have recently affiliated with Denver Children's, and so now Denver Children's is going to be giving some of the care there through that private hospital, as opposed to children coming to our children's hospital, which is less than a mile away. And so we would never be able to coordinate with that private hospital because they historically have, and we historically have not wanted to play well together because it's a competition to try to take care of the patients and gather the market share for children. Okay? Many times when you're looking at systems of care, you're really asking the state or government and regulatory institution to come in, and that's a really heavy lift for many states that are political. New Mexico is a very political state. And then there's sometimes very poor coordination. Once the child is seen, then they go back to their community. When you're working on systems of care, what's the infrastructure in that community now to take care of that kid with a trach, or to take care of that kid on home event, or whatever, however they've been discharged. As far as the off-site consultation, that really does improve care. It gives non-specialty capabilities, at least some advisement to those outlying facility, which I'm going to start calling originating sites, because when we talk about telehealth, that's kind of the lingo, is originating sites. It allows patients to remain in their home community many times, and it reduces time and costs. I'm sure you see the same thing, but we will, get transfers in from parts of the state. It's February. They get flown in, and they get discharged from the emergency department within an hour after we've seen them. And now it's 2 in the morning. The family hasn't even arrived. The roads are icy, and are we really going to send the family on the road, to drive 4 hours home? Just had we been able to consult on the kid remotely, we wouldn't have to do that. So it does allow, with telehealth and regionalization, it does allow the child to remain and the family to remain in the community. There's a limited number of conditions that are amenable to this, so certainly surgical services couldn't be amenable, although, believe it or not, they're working on that with telehealth, with virtual hands, et cetera. Not sure how far that'll get, but it sounds really cool. But there are limited conditions that are amenable to that. Limited evidence as far as that actually works or makes sense, but there is some evidence, and the body of evidence is growing, okay? And it does require cooperation and collaboration, again, between specialty and non-specialty hospitals, which can be problematic, honestly. Okay, so when we're talking about regions and regionalization, these are just some examples of some of the regions, all right? The left upper are the HHS regions, the CDC regions for disease control. And you can see that we have been split. You are in Region 9, and we are in 6. We're with Texas, Oklahoma, Arkansas, and Louisiana, and you're with Nevada and Colorado. But when we think of HHS regions, that's disease control, right? Well, if the the map below that those are the WHO flu regions. And notice those regions don't quite match the regions above, okay? They're pretty close. Well, they do match with the FEMA regions in the right upper corner, okay? But they don't match with the foodborne disease surveillance in the far, this one down here. So it seems to me that this should be the standard for all of them. It only really works for FEMA because those are federal government. Doesn't work for WHO, doesn't work for foodborne. Texas is clumped with us in the Rocky Mountains. Doesn't make much sense, especially for things that really require communication around specific diseases, around specific processes, and care. EMS for Children also has regions, and we have the Rocky Mountain region, and then all the others are designated. These match more the WHO regions than any other region, which is interesting since it's federal also. I'm not sure how that all occurred. In New Mexico, our regions really don't match at all. So this is the, these are the public health districts. We have 5 of them, 1, 2, 3, 4, and 5. The Albuquerque area, Bernalillo County, is a region of its own with only 1 million people, but nonetheless, that's a region of its own. Then these are other health regions. They don't match. These are the EMS regions. We have 3 EMS regions, and they don't really match. This county up here falls with this region. Torrance County falls with this region, so you have some overlap, but not a lot. And then when you look at a regional map of environmental emergencies and how that response is, it would seem to me that this should match this one, and it doesn't. There are 3, and they go horizontal as opposed to kind of random like the EMS one. So I think there's some problems there. You guys do a little bit better job. This, of course, are your Department of Health regions. They mostly match your FEMA equivalent here, with the exception of Yuma County. And these are the government districts, and they kind of match, except they've divided this area. I imagine that's political, but I'm not sure. And then these are Health Coalition. This should match this one, and it does not. This is Healthcare Coalitions, and this is Department of Health. I think they should probably be closer affiliated to get work done, but I'm not sure. So how does this all tie in with children, and how are we trying to make a difference in New Mexico anyway? So HRSA and the EMS for Children program developed about 8 years ago a pediatric readiness program. I'm not sure if anybody's familiar with that program, but it's a national program where hospitals can get online and they can complete a survey, and then it spits out their score immediately for preparedness for children. And then it compares them to the state, it compares them to hospitals of similar size, et cetera. In essence, it's a categorization program. There's no verification, no designation. It just gives the hospital that information, and they can use it as they will. This is what the scores look like. So these are our state numbers here, and I don't know what Arizona's numbers are. They don't publicize them. Not Arizona, just the feds. I don't have access. I only have access to New Mexico numbers. But so it gives you the state average of a 68%, which isn't so bad when you look at the national median score of preparation for children. It's 69. So our score 68, 69 isn't that bad, except when you drill down. So this is one of our telehealth sites, and their score is actually 49. Okay, even though they contribute to the 68. Their score is only 49, so they have some ways to go. And so that's what we're trying to move, that's what we're trying to help them with, is to increase their preparation for kids on the local level. Hopefully then we'll be able to increase our scores statewide, but we're really working on the local level. And those questions and those surveys involve questions such as equipment, pediatric size equipment, training of your staff, whether children are involved in disaster planning for your hospital, whether children are cared for, if you have a QA/QI process for children in your emergency department. So as part of that, HRSA then developed the State Partnership Regionalization of Care Grant programs, and those were funded 5 years ago was the first funding, and there were six regions, or 6 states rather, that were funded: Montana, UC Davis, Arizona, and that sat with the Department of Health with Tommy St. Mars, Alaska, and University of Pittsburgh, and New Mexico. We finished that 4 years of grant funding, and then we had to reapply for, they only were going to fund 3 sites after that, and Montana, Davis, and New Mexico were the ones that were awarded that grant. Arizona did not apply for the grant, so it was a blessing for us, because I think we would have not gotten it, so, because you guys do tremendous work here. But we've been working on regionalization in New Mexico for a very long time with limited resources, and only the one children's hospital, as well as large distances, just like you all. In 1996, we did site visits to various hospitals to assess their capabilities. We visited 20% of the hospitals in New Mexico. In 2006, we repeated that, so 10 years later, we repeated it, looking at their capabilities, and also looking at what it would mean to do regionalization. Would hospitals be willing to sign up for such a program? Would they think that's important, et cetera? And we decided, mostly because of the culture in New Mexico, that probably would not work. So that's kind of what we're battling with, and that's why we decided to think a little bit outside the box. And that was with the Child Ready program. So the way we approach regionalization in New Mexico is much different than the other 5 sites that we're doing it. The other 5 sites really focused on designating the hospitals or the facilities and making sure they were ready to take care of the child in an emergency setting. We didn't think that would work in New Mexico, very limited resources, and we really needed to rally more of the community. And so we actually do a community engagement approach to regionalization of care. And we'll talk a little bit about that, and we named it Child Ready because we think the entire community needs to be ready for the child in that emergency setting, whether the emergency occurs in the school, in the back of an ambulance, in a clinic, or in the ER. All of those areas need to be prepared to take care of the child in this emergency setting, not just the hospital or not just the ambulance. So in order to prepare for the extraordinary, such as disasters and all of that, you really have to be prepared for the ordinary: status asthmaticus, status epilepticus, those normal, usual things that occur with kids that can really wreak havoc on an institution if they're not prepared to take care of that child. And because of that, we're really helping the whole community get ready for that, because the asthma attack could start anywhere. The seizure could occur anywhere. The AAP has helped us with a policy statement. They're ensuring culturally effective pediatric care, really reaffirms the importance of establishing and promoting organizational policy on the provision of culturally effective pediatric care, which is why we employ a cultural liaison to help us, working with tribal communities, et cetera. Like I said, we bring about a community engagement model, and so there are several aspects when you're doing community engagement work. So you have to involve the community, involve stakeholders, involve their political individuals in the community, et cetera. That's environmental. Membership, and this is what we struggled with a great deal during the project, is respect and trust, and rebuilding respect and trust. The university didn't have a very good reputation when we went to the communities, and here we were bringing another university program, and it didn't have a really good reputation. So that was really hard, something we had to work through. Process and structure had to be clear in roles and guidelines. We do a formal facilitation process when we're working with communities and doing a community engagement project. Communication needs to be open and frequent. This has been also very challenging with communities. I'll explain that in a minute. And the purpose, we need to get the community on board to have a shared vision for what they want, or what we want, or what we think we want, to be able to care for that child in the community. Okay. And then resources, both on the community level as well as our team when they go into the community and help them. Okay. We also know culture can affect health. Okay. Information obtained by healthcare providers may be incomplete due to languages and unfamiliarity with the patient's culture. Okay. Information that's given to the patient may not be clearly stated or clearly understood. Some of that may be due to low or marginal health literacy on the part of the patient, as well as us not being able to communicate at that level of health literacy. And then the imbalance of power that exists, whether we, as healthcare providers, whether we want it or not, and as much as we state that most of us don't really see ourselves in that role, there is a fair amount of power that occurs and happens in a clinical setting between a patient and a provider. And so all of those are the culture, and then those can then ultimately affect health and healthcare. So we're trying to bring together the culturally appropriateness of what we do with community and community engagement model, and really striving to give culturally appropriate and culturally effective pediatric health care on the emergency basis to outlying areas. And that's why we developed Child Ready. And currently we're Child Ready New Mexico. Montana has adopted the name, and there's a Child Ready Montana as well. So we're partnering with communities, and we're trying to reduce morbidity and mortality while making sure that it's culturally appropriate care. Okay, so we're preparing, the entire community are trying to anyway, communities, facilities, and providers. This is our website. It's child-ready.org. You may not be interested in the website for purposes of the talk, but we also, as part of the program, offer over 40 hours of continuing education on there around pediatrics. We have a freestanding 8-hour video-based pediatric emergency trauma course on there. That's all scenario-based. We have 6 hours of behavioral health emergency training for individuals, as well as 16 hours on just general emergency care, and the remaining other topics such as DKA, status epilepticus, et cetera. We do, for nurses, give continuing education units for that, and for EMTs as well. We do not give CMEs on that, but you know, they're kind of interesting modules. At the bottom you can see an example that we have 2 modules on safe transport of children in the back of an ambulance, and it reviews car seat technology and using it in ambulances, et cetera. Most of them are video-based, so mildly entertaining. This is where we're working. We're working with all of these tribes in New Mexico. Most of ours are Pueblo tribes along the river, the Rio Grande. But we are working with 2 Apache tribes, as well as, this is another Pueblo here, as well as we've started to work with the Navajo Nation in all of this as well. And the very rural communities. This is near the Mexico border. So we do community site visits, and we identify a community champion. Many times it's a pediatrician in the community, but it may be an EMS provider or a nurse, anybody that's a community leader. We help them organize, and we schedule a community meeting, a half day, where we come in, facilitate that with the community members, and they review their community. They go through a checklist, resource inventory, and they review their community to look at their capabilities to see if they have the components in order to take care of that child in the emergency setting, whether it's in the school or the ambulance or clinic, et cetera. We involve community health workers, community leaders, school nurses, emergency managers, hospitals, EMS. We start the meeting by them determining what is their community, which has been incredibly insightful for us, because we went in with all these assumptions, and we were completely wrong in most of the communities as far as what they identified as their community. Okay. This is a community meeting that occurred in Silver City, which is just in the southern part of our state. It's north of Interstate 10, but it's almost on the Arizona border. And some key individuals. So this is Dr. Etheridge. He was our community champion, and he's a practicing pediatrician in the community. This is our team over here, as well as Lifeguard, which is our transport service. This individual is emergency manager for the city, EMS director, and happens to be the mayor of the community as well. And so it just is nice to be able to have that level of participation in a community meeting. This was a WIC worker, and I think this was a school nurse. Okay. So when we started by saying, okay, what is your community? This is what we think your community is. This is your population. These are your demographics, et cetera, et cetera. It didn't take long for us to learn that we were completely wrong. So this is an example of a community meeting that we had in Des Moines. So Texas is right here off the screen. Clayton and Raton were the two communities that we were trying to bring together to do this community meeting, and they said, well, let's meet in the middle, let's meet in Des Moines. This is, by the way, about 4.5 hours by car from from Albuquerque, and there's no easy way in, just these two roads. So when we asked them, okay, so what is your community? We were expecting them to say, well, there's Clayton and then there's Raton. But then they started to list all these, and there's no roads between these two roads. They started to list all these communities that their EMS responds to, all these different smaller areas and ranches and communities that all transferred to Clayton or to Raton. And so we really learned quickly that we need to broaden, when we talk about community, we really need to broaden our words around that and our communication around that, because it's not just what we thought it was. Okay. So we've been statewide, and it's taken many, many visits to these communities to get, telehealth, to get them on board with having a community meeting even. And that's resulted in, we've traveled over 64,000 person miles in the program so far in the 5 years, just getting to all these communities and getting them engaged. Okay. Some of the lessons that were learned was an incredibly strong sense of community. I don't know if you have it in Phoenix. I don't think we have it in Albuquerque. In the cities, we tend not to. But if you go to these small communities, they are incredibly proud of what they have. And they are doing some really fantastic things in these small communities, not reserved for just big cities. The community is much more widespread than we anticipated, which is what, the last slide that I showed you. The community visits facilitated a lot of local collaboration also. So when I said the WIC person was there, if we have an early childhood development person there, or school nurse or whatever, during every meeting at one point or another, one community member said to the other things like, you do that? I didn't know you did that. And their offices were, in the next building or 5 miles away or whatever. So it really kind of facilitated that as well. The other thing we found were the needs really outweighed the scope of the project. So it wasn't uncommon for us to hear things like, oh, well, the project's great and everything, but we really need a pediatrician in the community, or we really need a pediatric clinic, or we need a new hospital. So the community expectations of what we were able to provide were way out of jive. And then we had a lot of work to do to overcome the trust from the past. So, one community member said, well, the university was here 4 years ago. They did a project with youth drinking, and we never got any of the results. Why should we trust you? Why should we let you into the community? Why should we participate, basically? So we've had to do a lot of work overcoming those trust issues. And frequent personnel changes. So in these small communities, there are, a few very, very capable people that take on a lot of different roles and wear a lot of different hats. So the chief nursing officer for the hospital may also be the director of the ER, and then he or she may change roles in the middle of the project, and then they may no longer answer the emails or the phone calls around this project. So that's been really, really hard. It's a lot of change in personnel. And there's been a lot of change in tribal leadership as well. They have elections periodically, anywhere from 2 to 4 years. By the time that new administration comes in, it's really hard to get on the docket again to speak with that new leadership. And remember, their native tribes are sovereign nations, and so having to do literally international negotiation is what we've had to do many times. So when we started, this is what we thought we would do. We'd contact the community, we'd do a site visit, hopefully get telehealth set up for them, and then have some ongoing engagement. But what we ended up having to do was we had to contact the community several times. We had to do several site visits to many of these communities before we even got the community visit set up, or the community engagement process set up. And for telehealth, we've had to then visit yet again, sometimes several times. Sometimes the communities have had to come to Albuquerque just to negotiate and talk about it again, and then ongoing engagement. So it's been quite the process. But out of all of it, we were able to identify 3 main domains, or 3 main things that the communities really thought they needed to get more prepared. So one was a new design or model for regionalization. We'll talk about that. a telehealth access in the rural communities or originating sites. And then they were really adamant about needing injury prevention in their communities and some sort of process for injury prevention in their communities. And so we set out to address these, and that's the new project, is we've set out to address all three of these. So when we talk about regions and regionalizations, and the community said, yeah, this isn't working for us, there's a lot of different models. So there's the spoken hub here, okay? There's a modified spoken hub where you have some communication between outlying hospitals. You may have mini hubs. This is more the Los Angeles County system. And then you have a full integrated system. But classically, we think of it as a spoken hub. So you have the tertiary care center here and the communities and community hospitals referring into the tertiary care center. Well, our communities, when we talk to them, this isn't how they see themselves, okay? Yes, they see the tertiary care center as a resource, but they don't only see this kind of care. They see this kind of care as well, okay? And some of the communities have said, well, we want to be a region. We don't want to be in your region. We want to be our own region. And so because of that, we developed something that looks more like this for regionalization of care. So you take away the spoken hub, and then you have these regionalizations. So an example would be Gallup, for example, okay, and Crown Point, which would be in this part of the state. Crown Point, which is actually not far from Albuquerque, it's like an hour and a half, they tend to communicate with Gallup Indian Medical Center in Gallup about children. And those pediatricians from Gallup Indian Medical Center will do phone consultation with Crown Point. And in fact, Crown Point will send them to Gallup as opposed to sending them closer to Albuquerque, okay? And so that's where we need to then help Gallup Indian Medical Center be prepared for kids, but we also need to help Crown Point be prepared for kids better, okay? So all of this, so the community then becomes its own region. The other thing that we've really been pushing, and this is one of the main thrusts of what we're doing, is developing a telehealth network. And we're building a virtual pediatric emergency department. And this is just an example. This is in Clayton. This is a nurse practitioner out in Clayton. We're conducting a simulation. This is Dr. Jolly, one of our new attendings. He's in Albuquerque. She's 4.5 hours away from Albuquerque, and they're conducting this simulation via telehealth. Okay, so this would be called, this is an originating site. And what exactly is a virtual pediatric emergency department? Because we wanted to make it different. See, there I go, I, but it's really we, it's really them. So we wanted to make it a virtual, so that people have the sense of being on shift together in these originating sites. Our hypothesis is that'll help with provider retention in the community, as well as support, okay? So we do direct patient care and consultation and co-management. So that dehydrated kid, that kid with croup, et cetera, we can consult with them, we'll keep them active on our side, and we'll check in with them in a half an hour and look at the kid again with telehealth. To those ends, we use Cerner. I don't know what you guys Epic? Epic? Oh, so with Cerner, we have patient tracking boards in the ER. We have our pediatric ER tracking board, as well as all the other emergency departments. But we have the ER tracking board, but we have a telehealth ER tracking board as well. So these patients then get put onto that emergency telehealth network tracking board. So that way, when I sign out a kid that I've been taking care of in Clayton, for example, then I can sign him out to the next attending, and they'll be aware that that child's out there, and we're co-managing that child, okay? We've designated a medical director. Dr. Bullard Barrett, who is our new medical director, has been involved in building of at least four pediatric ERs around the country, bricks and mortar, as well as services. And so now he's applying those skills to building a virtual ER. Patients are registered and receive a medical record number in our hospital, whether they get transferred or not, okay? And we document in our EMR about that visit. And all of our physicians in the ER are credentialed with our originating sites. So now we're talking about, there's 10 pediatric ER docs there, plus another 15 adult ER docs that work part-time in the pediatric ER. So all 25 of those physicians, we're having to credential them at each of the originating sites. and we have 10 sites right now, so we've had to credential 250 of them. And we're trying to create a culture of being on shift together. So certainly it can be used for the acute, very chronic, very critically ill child, but we're also really encourage them to use it for, you know, a second opinion. Let us look at the rash. Let us look at that ear. Let us look at the throat. Let us do all of those things. They have access to pediatric emergency specialists as well as child abuse specialists. So our CART team is starting to do child abuse evaluations through the emergency department to the outlying facilities as well. We also are actually doing truly telehealth, so we're not just doing telemedicine. Telemedicine is where you just do the clinical care. Telehealth is where you include education as well. And so Sarah Dakin on that first photo, our nurse educator, is doing education across the network. She attends the staff meetings every 2 weeks at Mescalero Apache Reservation. That's 2.5 hours from Albuquerque. She attends their staff meetings twice a month and gives a half-an-hour talk to those nurses in that health center. And she also does other formalized talks as well. She's giving talks and developing a curriculum on QA/QI, as well as challenging case discussion for the outlying facilities. That way, when it comes for them to answer their questions for the Pediatric Ready National Survey, they can say, well, yes, we do have a QA/QI, pediatric QA/QI process. We do it through telehealth, and we do it through Child Ready. And we're really trying to get them to budge their scores, which will help the state budge their scores, and it's all through formalized as well as informal education that Sarah provides. This is one of our older hospitals, one of our sites in Truth or Consequences. It just has a really cool name, so I thought I'd put it in there. Other things that we've developed for the project is each of the outlying facilities has a little bit of information about our hospital, how far it is, et cetera. And we have accompanying information from the hospital on our side, so we know what these hospitals are capable of. And that's because, you know, you hear residents getting transfers in or whatever, and they'll say, well, get a CT before you send them to me, or put an IV in before you send them. And some of these places don't have a CT, or trying to put an IV in a child is will actually delay the transfer and not be a good idea. We have a lot of education for the sites on how to use the carts. The carts are single screen touch. It's pretty easy, but nonetheless, we've done that. We have information and trainings on etiquette on telehealth, because there are specifics to when you're interacting on telehealth that we have had to work through. And we've developed flyers for patients as well to be put in the originating sites for the emergency departments. And we've developed them in English, Spanish. We have a draft here in Navajo, and then the Zuni language as well. And I'll just pass these around. And what those are designed to do is to inform the family that that their community has these capabilities. That way they could connect. We're not at all trying to devalue their local providers. It's really just giving them information that these are available, that this service is available in their local hospital, and they can ask for that service if they would like. Okay. So how does this work when you're looking at telehealth? So just to review the model and the overlapping, and I alluded to it a little bit when I talked about Gallup and Crown Point. But for our telehealth, if we start with Union County, which is Clayton, New Mexico, so that's this star up here almost on the Texas border. So if we're doing telehealth with Clayton and advising them on the management of a child, that's really a nice interaction, but Clayton doesn't usually transfer to Albuquerque. They usually transfer to Amarillo, okay? So that's their transfer pattern. So we need to, since we're involved with that child's care, we need to be communicating with Amarillo as well, okay? And so that's how that regionalization works, is that we're all regionalized, okay? Each of those is a region, and we have to communicate, and we're overlapping. This is what our telehealth network looks like right now. We have 10 sites. Zuni Comprehensive Community Center, which out is in the Pueblo of Zuni. There's Sandoval Regional, which is one of our community hospitals in the university system, about 20 miles away from our mother site, Clayton, Santa Rosa, which is, this is I-40, lots of high-speed crashes occur there. Truth or Consequences, Silver City, Mescalero, Apache, which is our highest producing site, Artesia, and Roswell, one of the hospitals in Roswell. And within the next 6 months, this is what we're anticipating. We're going to be delivering a cart to Shiprock. We just signed the professional service agreement with Rehoboth, which is one of the Gallup hospitals, and we're working with Navajo Nation to do GIMC, Hickory, Apache, Redtone as well. We're also working with, partnering with your Department of Health and Tommy to get some sites in Arizona. And we are going to be, we're negotiating, we're working with National IHS headquarters in DC, and we will be having a site in Welpanet Health Center up in Eastern Washington, and we'll be talking to, we've had discussions with Montana. They're considering, some of the tribes in Montana are considering it, and we'll be talking with Cass Lake within the next month to try to get a site up in Minnesota as well. And next week we'll be in Oklahoma City talking to tribal leaders to try to get sites in Oklahoma. So all of them will be doing the virtual pediatric ER, hopefully nationally, within the next couple of years. Our numbers are kind of disappointing. We've only had 24 consults, but we've saved 7,200 miles transferred in transfer. There's only 5 of the kids have been transferred, and even with those small numbers, we've almost saved $1 million for the healthcare system. Now, I'm not sure where that $1 million goes because it's not going to our hospital or any of the other hospitals, but it's not being spent, that we know. We've had 59 educational sessions delivered so far. And the last thing is injury prevention. And so what we've done to address that for our communities is we've developed an app, and you can download it. It's free. You can give it to your families to download, the hot link on Google Play. It's available both for Android and for i products. That's our icon there. It's called Child Ready Home Safe. This is what the opening screen looks like. You press on the Start button, and it takes you to the outline layout of a home. And then you can press on any of those rooms, and it'll show you all those are places a child could get injured in that room, the kitchen, for example. And say you press on 7 up here, it'll show you, it gives you then prevention activities around that and what can happen for choking, for example. If you go back to the layout of the home and press on another room, say the laundry room here, it'll take you here, and these are all places a child could get injured. And for example, if you press on 2, it shows you Tide pads, Tide packs, etc. Okay, so this is available for download for your families, and we've rolled it out to the communities. So far, we only rolled it out in February. So far, we've had downloads from 10 countries around the world, and over 200 downloads to date. And growing, so that goes up about 10% every other week or so. So it's catching on, which is good because I think it'll be a good prevention activity for kids. That's our project. Child Ready. Questions? Mm-hmm. So our telehealth coordinator, what we do is we document the consultation note in our record, and then that gets printed and faxed to the originating site. And then our telehealth coordinator then contacts them the next day just to give them an update. Other questions? Yes? So liability we'll tackle first. Since we're a state entity, we're covered under the state liability insurance. For that reason, that's the reason we get credentialed at the outlying hospitals. That's what our lawyers have told us will protect us. So we get credentialed and privileged at the outlying hospitals. As far as billing and coding, we do have a model for sustainability. This is all grant funded, so currently we do not charge for consultation, but we do have a model set up where we will be billing the patient for the services. The project we're working with National IHS, so we're billing IHS, since that's outside of the scope of the grant, we're billing IHS specifically for each consult. It's $250, I think. Other questions? Yes?
Currently have 10 sites. Do you anticipate it spreading a lot more around the state? I'm sure some of the slow process.
Yeah, it's been a lot of work, but so about 4 more are coming on in the next year, and then the ones nationally is what we're working on. So it is a very slow process. Other questions? Do take a look at the app. I didn't spend a lot of time on it, but it's really cool. We're converting it into Spanish. We're developing an asthma prevention app as well as a cultural humility app as well, as part of the new project. So, okay. All right. Thank you.